All right. Well, hello, everyone. I hope you can all hear me well and see me well. My name's Chris Urbanek. I'm one of the physicians for Regenexx Des Moines. This is going to be kind of our webinar series that we're going to start really getting pretty much ramped up again to cover a lot of material. I think for today, my goal is going to be just to kind of give an overview of what Regenexx offers and kind of what we do here. And then we'll certainly leave time for questions. So if you have any questions or comments, definitely just post it down in the chat, and then kind of as we go through, we'll make sure that we address all of those. So kind of our goal for moving this forward is, again, we'll do kind of an overview today covering, again, just kind of what Regenexx offers and what we can do. And then our next step will be kind of getting a little bit more specific so we can address more particular conditions, complaints, injuries, whether it's low back or extremities or trauma, and that way we can keep things pretty focused on whatever anyone is interested in. So this is really kind of a flexible venue. If you have ideas or things that you'd like us to cover, certainly post that in the chat as well. But otherwise, we're going to kind of move through, and I'm going to share my screen here, and we will get us up and running. Good. So we should have kind of our screen pulled up here. This is kind of, again, we're talking about Regenexx, and we've been around for a fair amount of time. The company really started in 2005 out at our Denver headquarters. And that's where it all began. We're first in the world to really move it along. And we've been studying it since 2005 as well. So we'll hit on some of those points. Not only do we have a full research lab where we continue to promote the research and development of orthobiologic conditions, but we also keep a registry. So our patients that we treat, we track their outcomes. And so that gives us a wealth of information when patients ask, hey, what do you expect me to be able to get out of this? Or how likely am I to get back to throwing a baseball? That we have the registry to kind of fall back on as a reference that we can show patients, yep, this is what you should expect from your improvement. And not moving forward. So basically, in a nutshell, what is interventional orthopedics? And so, first of all, this is a term that was really created by Chris Centeno, who's the head CMO for all of Regenexx. And it's a term that we've created because it kind of fits in its own little niche. We're not just kind of non-operative, first touch primary care type doctors, and we're not in surgery. And so it's kind of similar to the way that interventional cardiology actually came up. There were cardiologists that were able to do more, but weren't doing cardiothoracic surgery. So it's similar to that. And kind of, the basic principle is that we're using some form of injection that promotes the healing of body tissue. And that can be anything from, again, bone, tendon, ligament, muscle, cartilage, all of those areas can respond to our treatments. And so that's kind of the underlying idea. Importantly, we also want to make sure that it's going to the right spot. So there's, many physicians throughout the world that are doing their injections without any sort of guidance. They're pushing on the area that hurts and placing the needle there. And so we found that accuracy does matter for this. With injections such as like steroids, that's more or less a hand grenade. The steroid will go anywhere near the area that it's injected. But when we're placing cellular tissue that has metabolic activity and a local environment effect, we really have to make sure that it's in the right spot. And then kind of the last part that I was kind of getting to already is that we're continuing to promote what we're doing and looking at the research and development as far as what may be next in the future. So where do we kind of fit in the realm of musculoskeletal management? So if we have, kind of as I was talking about, the primary care physician, general MSK physician who's doing primarily steroids, they're on kind of one end, and on the other end is the orthopedic surgeon. And so it's a really quick jump from, the conservative management of steroid injections, medications by mouth, physical therapy, to cutting part of your body, and that's what surgery is. And so we really kind of fill in the gap between that. And so again, looking at kind of what the average general physician might do, really simple injections, typically of large joints, typically not without guidance. And then you go up a level. There is a group of doctors that are doing more ultrasound guided procedures, fluoroscopic guided procedures. At different levels. So maybe it's physiatry, maybe it's sports medicine. There's lots of different groups that are doing this. And so that's kind of, the in-between step. And then there's really making up us, which is the sorry, my screen keeps freezing, which is, again, this interventional orthopedics. And so it represents a much smaller piece of the pie for all of kind of the regenerative medicine physicians, but we fill a really large gap of the space kind of between the simple injections, just looking at it as the joint hurts, so let's treat the joint, to all of the other structures that provide either support to the joint or contribute to the function of the joint. So we really look at this as a holistic puzzle that we put together to generate a treatment plan for the patient. And so what do we treat? The short answer is everything. If you can get a needle to it, we can certainly provide treatment to it. And so, headaches can come from many, many different causes. It can come from neck arthritis, again, neck degenerative disc disease, strains of the ligaments, instability of the ligaments, TMJ. And so all of those things can really be treated with what we're doing. Neck pain falls into that same category, degenerative disc disease versus arthritis versus instability. And it's not just one condition. These things can often overlap, and they can be involved with other areas like shoulder pain, chest pain, rib pain. And so really being able to see all of those together provides further treatment advantage. Upper back pain, this is an area that we typically see get neglected in a lot of fields where, you may have an interventional pain type physician who treats cervical or, upper neck and lower back, but there's kind of this dead zone in between that no one really addresses. But the ribs are dynamic, the joints in that area are dynamic. All of these things move, which means that they're susceptible to injury. And so that's something that we focus on as well. Commonly, we see shoulder pathology, rotator cuff tears and tendinopathy, irritation of the tendon, as well as the cartilage that lines the joint called the labrum. And so we're able to get to those areas with just a needle without having to cut or put a camera into the shoulder. Hand and wrist is another one. So, texting thumb and the arthritis that's associated with it at the base of the thumb is a very common area that we treat as well. And then our low back pain, many people call sciatica or radiculopathy, SI joint, disc bulges, nerve irritation, also all amenable for our treatments. Hip arthritis is another big one. If you're struggling with hip arthritis, we typically find that that's an area that progresses pretty quickly. And so the arthritis can get worse very fast. And with our treatments, it's easier to fix a smaller problem than a bigger problem. So if we're able to address it sooner rather than later, we're able to get some better outcomes. And then, of course, knee osteoarthritis and ACL tears. So I can tell you that I trained in sports medicine at an orthopedic center where ACL reconstruction was huge, and it was a major part of what we did. But there's more and more data that for what we think is about 2/3 to 3/4 of ACL tears, they're actually amenable to treatment with orthobiologics, and we could potentially save patients surgery from that. And then certainly, down foot and ankle, plantar fasciitis, ankle sprains, Achilles tendinopathy, we address all of those pretty regularly as well. And all of this makes us, fairly different from what you may see out there. I'm also on the ethics committee for the Interventional Orthobiologics Foundation. So I'm always looking at other clinics and who's doing things kind of the right way and who's doing it not the right way. And in our Regenexx group, we're a large network of over 70 sites now. We've all kind of have a standard approach to the physical exam, to the way we do our procedures, to the way that the blood products are processed. And so you're really getting kind of the highest quality care that's out there. And as I started to mention earlier, we do all of our injections under guidance. So we have both fluoroscopy and ultrasound, and it's not uncommon for us to use both at the same time. So we're really able to pinpoint where the pathology is and guide the treatment so it goes exactly to that area. We also do all manual processing for the blood product. So when we make something like a platelet-rich plasma, or we're using cells from the bone marrow, it's not uncommon in other areas of the country that treatment is being done on a bedside centrifuge. So it's in the clinic. It takes 10 minutes to spin down the product, and they pull the cells out of that. We get much higher concentration using a full lab. And now certainly that requires more resources and staff, but we have a sterile lab room that we prepare all of the product in. And it takes about 3 to 4 hours. So it's more time intensive, but we can get the concentration much higher and really develop a better product that's more likely to get success for the patient. Our major, again, like I said, our major clinical or medical headquarters out in our Denver office is where our research and development team is located. And that's a massive lab that we're continuing to get research out of so that we're staying at the forefront of all of this orthobiologics so we can best provide treatment. There's a fellowship program as well, which I'm actually a product of. I did the fellowship program with Dr. Centeno and Dr. Schultz out at the Denver office. And so the key point to that is that, again, we're staying on the forefront. If we're teaching the next generation of physicians how to do this appropriately, we have to have the best evidence. And so we have to know everything that's out there. And that's kind of one of the underlying principles of really all of our research and development and the fellowship program that we have, is to make great doctors that can use this treatment effectively to, again, get the best outcomes. And then the other thing is, as I was saying about our network, there's a group of over 70 providers now, and we all work together. And again, by having kind of those set standards of highly skilled, highly trained physicians, they're also our collaboration. So we have a network that we can call on if an odd injury comes up. If we haven't seen it before, we have partners that we can reach out to and say, hey, what do you think about this? Or what do you think this approach is? So you really have this whole network of knowledge behind every treatment that you get, ensuring that you are getting the best quality treatment from the highest trained doctors that there are. And so, going on and talking about specifically, I've been talking about treatment, but what is the treatment? What are the things that we do? We generally consider it orthobiologics. You hear many people also say regenerative medicine, and the two are usually used interchangeably. But there's many things that we can do to treat patients. Certainly, we talk about some growth factors and cytokines. I'm going to spend a little bit of time talking about that more later, but this is primarily what we're getting out of our platelet-based treatments. The other thing that we have is bone marrow. So this is more cellular component. We take the cells out from the bone marrow, or we can harvest it from fat. And we use that to take those again, what most people call stem cells, and inject those into the area. And we're going to talk a little bit more about what effect that has. One of the other things that we're seeing more of is amniotic type fluid. We typically don't use this in isolation, these allograft or tissue derived from something else. We typically don't use it in isolation, but we may combine it with our treatments. There's lots of evidence, again, kind of talking about those, the other stem cell clinics. Many of those clinics say that they're doing stem cell injections, but they're using an amniotic product. And in order to make that amniotic product safe for injection, it has to be irradiated. And all of that radiation does a really good job of killing stuff like HIV, hepatitis B, hepatitis C, but unfortunately, it also kills any stem cells that are in there. So it's an adjunct product, but not one that should be used on its own. And like I said, many of these clinics that are out there are also saying that they're injecting stem cells, but what they're really injecting is amniotic product. And then the big one is our concentrated platelets. So with our manual processing, we can really ramp up our platelet concentration. We do know that there is a dose response curve associated with platelets. And what that means is that the patient's response or ability to heal after a procedure is entirely dependent on how many platelets they get. And we know that if you're under about 5 times your baseline platelet concentration, what normally circulates in your blood, your outcomes are going to be less than that. And many of the bedside centrifuges that you see in orthopedics offices, sports medicine, PM&R, they typically end up with a concentration somewhere between about 3 and 6 times. So in many of those cases, that it's not actually concentrated platelets, it's really considered platelet poor plasma. And so it's important to kind of know what the difference is between some of those treatments, so that you can gauge what you think will kind of be the best for you. We can also process the platelets differently as well. So when we're injecting around the spine, it doesn't do well to have particulates or substance in there that's gritty, so to speak. And so we use a type of platelet into the spine called platelet lysate, which gets rid of the cellular component, but is injecting primarily just the growth factors. Oh, good. Yes, thank you. Apologize. And so as we kind of talk about these individual parts, these, what is really effective or the effective component of these injections we're doing. And that's what we're going to kind of go over now. So our platelets are really like the delivery truck. They're bringing a host of growth factors with them. And those are, again, cytokines and growth factors. We'll hash that out in a little bit. And once they get to the area, they really release all of that, and it affects the local environment. That's our healing component. Just like when you cut yourself and you bleed, we all kind of think of platelets as being the thing that stops the bleeding. It's the clotting factor, and it is, but it's also the thing that starts the skin healing. So when the platelets are in that fibrin mesh, that clot that they've created at a site of bleeding, they're releasing all of their internal components as well. And those are the growth factors and cytokines that your skin uses to heal. And so we're basically just taking that same healing process and we're applying it to the areas that we're treating, whether it's a rotator cuff or low back or whatever. It's the same mechanism, we're just concentrating it. Kind of our next level up, it's our general contractors, and that's what a lot of us in this field kind of refer to them as, and that's the stem cells. And the stem cells are very, very powerful signaling cells. They talk to everyone else in the environment. They, of course, have their own innate metabolism as well, so they can release some of those growth factors. They have these cytokines that are signalers as well, but they're in there to really kind of negotiate the local environment. One example of this is we have cells in our body called macrophages. These are essentially white blood cells, to keep things simple. And those cells can be in a pro-inflammatory state, or they can be in an anti-inflammatory state. And the truth is, we actually want both of them in certain degrees. So a pro-inflammatory macrophage can restart a healing process. And then as that settles down, the anti-inflammatory macrophage can go in and calm things down and promote healing. And that's what the stem cells do. They send out those signals. When is it appropriate to be pro-inflammatory? When is it appropriate to be anti-inflammatory? And that's really how it works as part of our injections. The growth factors are exactly that. They're stimulants. It's a cellular metabolic stimulant that is going to boost the local effects of all of our native cells and the ones that are coming in from the treatment, whether it's platelets or bone marrow cells or stem cells. And then the cytokines are really the messengers. They're signaling molecules that can, again, both be pro-inflammatory and anti-inflammatory. And it's kind of our job to make sure we're using which ones appropriately. The big one that we tend to talk about is something called A2M or alpha-2 macroglobulin. And that's something that's found both in serum, which is in our blood, and bone marrow. And it's a powerful anti-inflammatory. And so we find that patients that have stuff like recurrent knee swelling, that just comes and goes, you drain it, it comes back. Supplementing with A2M can be nice to kind of quiet down those hot knees and stop some of that fluid from building back up. And so, what we foresee the future of this is that our interventional orthopedics approach of using orthobiologics is really going to supplant a lot of the operative management that's done today. And so, first of all, it's less invasive. We're using a very tiny needle, and I've got a video that I'll show shortly that'll actually show you kind of how small these needles are. And then the recovery is quicker because there's less stuff to heal. There's no plates, there's no sutures in the skin, and so typically the recovery is faster as well. And we haven't changed the native anatomy for the worse. So alignment is a big issue when we talk about knee replacements. How close is the angle of the knee to getting back to what it was before the replacement? The other one is, what's the position of the ACL? Is it in the same position that it was? And so by not radically changing biomechanics, your body's going to work with what's naturally best for it. It's not uncommon after some of these either replacements or surgeries that pain develops in other joints because of the altered biomechanics. Fusion is another great example. Lumbar fusion, where they put rods in the back to stop motion. That in order to kind of do day-to-day stuff, the body has to develop that extra motion at the adjacent joints. And those then see early wear and tear within as soon as 2 years. So this is something that, again, preserves kind of that natural function that we innately have. I want to show some pictures of kind of what it looks like, what we're doing. And so we picked a couple cases here, and we're going to show some of these pictures. So this is a knee procedure in one of our procedure rooms. So just looking at the left-sided picture, you can see a physician here. You see the patient's knee. And then this kind of plastic metal device is our fluoroscopy unit. So this is a live X-ray, and it's one of the ways that we do all of our needle guidance. We see a picture on the top right of the fluoroscopic image, and this is a kind of exact view that's in the picture shooting across the top of the knee, and you can see the kneecap at the very top, and this is the femur with its groove that the kneecap sits in. This is a treatment that we call bone augmentation or intraosseous injection, and so you can see a trocar going into the kneecap itself. That will likely be injected with a bone marrow product, and then you see a second needle that's going into the joint, and that's this guy coming here, with some of our contrast confirming that the flow of our injectate is going into the joint. And so this view up top, this fluoroscopic view, is really the same as our MRI view that we get. We don't see soft tissue as well under X-ray, but it's the same orientation with kind of the kneecap sitting on top and the groove that it rides in. And if in this patient, which is the same one, you can see this hot spot inside the kneecap. So the bone is black pretty much everywhere. And then in this area, it's bright white. And that hot spot is an area where the stress has gone into the bone and it's made it weaker. This is edema or irritation inside the bone. We also know that with conditions like chronic osteoarthritis, our local stem cell environments, the stem cells that live in our bones and all of our bones, become deplete because they're constantly trying to create repairs. And so one of the reasons that we will do a procedure like this where we inject into the bone is to replenish the local stem cell environment so the bone is better able to support the health of the cartilage in a case like osteoarthritis. This is a great procedure. I really enjoy this, again, just coming from a program that talked about a lot of ACL reconstruction. But again, in that 2/3 to potentially 3/4 of cases, ACL injuries can be managed non-operatively. And this is a fluoroscopic image of doing the same thigh. And you can see, again, thigh bone up top, shin bone on the bottom in both of these fluoroscopic images. The black is the contrast, and it's tracing out the exact pattern of both bands of the ACL. And these are, incredibly small, but we can hit that with accuracy and exactly go where we need to. Ultrasound does not provide adequate imaging of this. You can only see kind of the distal end of the fibers, but not the ends closer to the thigh bone. This is a great video. This is for, we're talking a little bit about those labral type injuries, the cartilage that lines the rim of a joint. And we're seeing a fluoroscopic or X-ray injection of that tissue. And specifically, it's this triangle that you see forming within the contrast at the superior aspect of the shoulder. This is the arm bone, shoulder blades over here. They've already done an injection where they treating inside the joint where the cartilage lives. And that's what this black contrast is between the arm bone and the shoulder blade. And then as you can see, the needle tip is directly in the labrum and it's tracing out that perfect triangular outline of the labrum. And so again, it can be very effective for treating labral type tears. This is a neat video, and to get you oriented before we play, this circular structure in the very middle of the screen that kind of looks like bunches of little grapes. This is actually the median nerve. So this is the nerve that's involved with carpal tunnel syndrome. And so we can treat it with a platelet type modality that treats nerves very well. One of the growth factors, IGF-1, is very similar to a nerve growth factor. So we do see really good results treating carpal tunnel syndrome without surgery. And so in this procedure, you're going to see the needle coming from the left side of the screen. It's an incredibly small needle, 30 gauge. Again, it's about the size of a toothbrush bristle. And the median nerve itself is quite small too. These numbers on the side are centimeters. So here, 1/2 centimeter from here, 1/2 centimeter to here. And again, we're going to see kind of the accuracy as this needle comes across. You'll see some expanding black. That's the platelet product that we're injecting around that nerve. So not only are we providing kind of the biological stimulus of the platelets or stem cells that we're injecting, but there's a mechanical effect of this as well. We're separating the median nerve from all of its attachments. So all of the adhesions or scar tissues are going to be broken up in that area. And so again, our clinic offers things that are different from everyone else. We were really the forerunners of this. We kind of started the process and we're continuing to advance it. So we're really staying on the front line. Our protocols are all research backed. So you can find our research on the Regenexx website, and that'll go through everything that we've kind of published. And again, we're kind of at the forefront of this, saying that, okay, not only do we have the science to make the product, but we have the research backing kind of our post-procedure rehab, which can really be just as important as the other parts of the management. All of us are fellowship trained physicians that have kind of advanced level of training and really a dedication to doing this product. And that's kind of true throughout the whole network. And so you're getting, again, kind of, that small percentage of physicians throughout the country or the world that have really dedicated to doing this the right way. And then our image guidance is at the top. So we are making sure that anytime we pass a needle, it's going exactly where we need it to. Close enough is not good enough. It has to be exact. And that's the way all of our procedures are conducted. We have one of the highest quality labs out there. We are manually processing all of the blood to get that highest concentration, highest safety, best outcomes from the biologic products that we produce. And we also grade all of our patients. So again, our job as a physician is to just provide information. And so when I'm meeting with patients that are new or interested in treatment, I say, look, these are all of your options. These are the things that we can do. And then I tell the patient, based off of either the degree of your injury, other health conditions, other treatments you might have had, I expect this outcome from you. And that's really kind of relying a lot on our registry data, because that gives us the gauge is where do we expect an average patient to come out, or of other patients that we've graded as fair, how have they done? So we've got this wealth of information from a large network that we can give a good prognosis as to what your outcomes we would expect them to be following one of our treatments. And then finally, as we've talked about, there's lots of different things we can do. We process the platelets many different ways. We process the marrow and the fat cells different ways as well. And then we have some of these other adjuncts that we can add too. And the big take home message from that is our treatment's not cookie cutter. It's not, oh, your back hurts, do the back treatment. It's very specific to where your pathology is, using a combination of your imaging, which might be X-ray or MRIs, as well as our physical exam to tease out exactly what needs to be treated to get you the best outcome. And so with that being said, I think now is a good time for us to take some questions. And so if we can, we'll check here on the thing. Bear with me, I am pulling up my meeting controls or stop the share. And so certainly if anyone has questions, I think this is a great opportunity. You're welcome to write it into the chat. And then we can certainly go from there. You can do it just to the panelists, you can do it to everybody. But if any has any questions that they want to go over, I'm certainly happy to discuss them. The other thing I would say is if you want to think about topics that you'd like us to go over in the future, my goal is again to move away from just this general overview and really getting into the nitty gritty. You know, what is our treatment for rotator cuff? What is our treatment for, say, degenerative disc disease in the low back or spine? And trying to move forward on specific things that more patients might have questions on. So we have one question being asked, and so this is from Eddie saying, how long would a hip injection likely last before surgery is needed? And so that's a very good question. So for the majority of our treatments, and again, if you go to the Regenexx website, at the very top is patient results, and then you can go and select by body parts. You can select hip and see what the outcomes are. And so our treatment's very different from steroids. If you've had a steroid injection in the past, you may note that you get a rapid improvement and then a fairly quick decline as well. And it doesn't treat the underlying problem. It only treats the symptoms of the problem. With our treatments, we're going to see a more gradual improvement. Usually there's some post-procedure pain that lasts a couple of days and then that goes away. And then it's a slow, steady process. And so it really takes about 4 to 6 months to see the maximum outcome from any one of our treatments. And so that's the one thing to keep in mind. But when we talk specifically about hip, and depending on many other factors, such as degree of arthritis and what our treatment was, whether we were doing something platelet-based or something bone marrow-based, we typically see about a 2 to 4 year improvement in symptoms after treatment. Now, some of those patients do come back for boosters, so where we repeat the platelet injections, or sometimes we escalate. If we did platelets before, we'll go up to a stem cell-based treatment. But our typical kind of goal, and again, I encourage you to check the Regenexx website under patient results. You'll see all of our registry data, and you'll see the average of how long we're seeing improvement for. Once the session, do we have access to viewing again? I don't know. I will talk with our administrative team, and we will see about if we're going to post this online or YouTube to get that out. Approximate cost for osteoarthritis knee injection. So that's a good question as well. And that can vary wildly depending on how much we're doing. So again, our preference is to treat the more mild to moderate conditions because we know that the patients respond better and we don't have to be as aggressive. And so compared to, end stage osteoarthritis, where we need to treat more areas, we need to regain stability. Sometimes we have to treat into the bone as well. And so that has a cost that goes up, but it's usually somewhere in the range of a couple $1,000, depending again on what all we treat. And that leads nicely into our next question, which is, does Medicare cover the cost? No, it does not. And so Medicare does not cover the cost of our procedures. It can cover your imaging and your office visits, but for our procedures, it does not. There are only a couple insurances that are doing anything with regenerative medicine. TRICARE is in a trial period looking at knee arthritis and tennis elbow, but many clinics that are doing this don't typically go through the TRICARE insurance because even though they say they reimburse it, it's at a level that doesn't even make up for the costs of the clinic for making the procedure. So many people stay away from that. The other alternative is in employers that do private paid insurance. We cover that through our Regenexx corporate. So we've got many groups that are involved with that, and through their employer, their services actually cover. And so you can, again, if you go to our Regenexx corporate page, you can look to see if you're with a group that has coverage, but some of those are other ways to get the cost mitigated. Another question from Jolie. Jolie says, generally, is a local or general anesthetic used? And so, wonderful question. Typically for all patients, we do a small amount of local anesthetic into and around the areas that are being injected, and that takes some of the pain away from the pinch of the needle. That's for the most part, that covers the many patients tolerate the procedure well with that. We don't do any general anesthesia, but we do mild to moderate sedation. And so the difference is that with sedation, we make you drowsy and not as aware. However, you're still breathing on your own. So it's really no different than when you kind of go to sleep at night. And so that can make things more comfortable as well for patients and certainly safely done too. I've got a question from Eddie. He says, is it possible for a patient to get imaging from us, analysis and treatment on the same visit? Is it possible? I'd say it's possible. That sometimes takes a lot of coordinating, but typically at our first visit, our new consult visits when we're first seeing a patient, we actually book an hour of time with the patient. So we spent a lot of time going through the physical exam, going through prior imaging. Almost all patients will get an ultrasound while they're in our office, and so that takes kind of a lot to come up with a good diagnosis, and then from that good diagnosis, a treatment plan. And so it is hard to get that all scheduled at once. And because to schedule our procedure, we need to know how long it's going to take, what all we anticipate treating. And we typically wouldn't know that before you came into the visit. So to have both a consult, an evaluation, and a treatment is quite difficult. But one of the things that, again, we can do is we can get all of your images together, we see you, and typically schedule treatment for another day. Brian is asking, if the knee is injected, how long should I expect that to last? Again, I would refer you to the Regenexx website. Go under the patient results. They're going to show you exactly by body part kind of what the anticipated outcomes. And for that area too, we're expecting about a 2 to 4 years outcome. And so again, I would have you check out the website. Okay. Switching over, Levon asks, if a doctor said a knee is bone on bone, is your treatment effective? Yes, I can tell you I've treated many knees that are bone on bone and get good outcomes. And so again, so if it's the more severe it is, the more we have to treat. And so that's more involved of a treatment and a procedure. But yes, we can certainly treat bone on bone. Brenda asks, did you say bone marrow can be extracted from fat, or referring to stem cells? I apologize. I may have said bone marrow comes from fat, but we have stem cells in both locations. We have stem cells that live in our bone marrow. We have stem cells that live in our fat, and both can be used for treating different conditions. And so we can harvest from either site. Have you used this for polymyalgia rheumatica? No, I have not. Typically, polymyalgia rheumatica is often managed actually with steroids, and it's one of the rare instances where I would agree that steroids are probably the appropriate course for that. But I have not treated polymyalgia rheumatica. PRP is often used to treat tendons. This is Richard Adams' question. Can it help to lengthen short tendons as well as shorten overstretched tendons? So it typically doesn't lengthen. But it does a nice job of kind of shorting or making more robust the tendons that are either unstable or lax, probably more so with ligaments as well. But no, it typically does not lengthen short tendons. That can be, physical therapy can do a nice job with that, and certainly at the far end would be surgery. The thing that I would, my question would then be though, is why is the tendon short, and what's the other things playing into it? So again, our goal is not to just kind of like find a thing and treat that one thing. It's to figure out why it's that way and treat the underlying cause. This is not just symptom management, it's root cause management. And so certainly, Richard, I understand your question, but I would be interested to dive a little bit deeper and see if there's other things involved in that as well. Brett has asked, I have a disc bulge at T5. Is there treatment for this? Losing feeling in right foot. So in general, yes, disc bulges we treat very well. I would not expect a thoracic level disc to cause symptoms into the foot, but again, we can, that's something we can see in the office for and really discuss the particulars of your case. And so, but yes, disc injuries, we can inject directly into the disc with biologics. We also inject into the epidural space, which surrounds the disc and the nerve, and that can be effective as well. And we really treat spine as again, holistic approach. It's not just the facet is injured. If the facet is injured, then we know that there's likely some instability as well, and there's increased stress on the disc. So we really have to think about how all of those things play together. I believe this is Deborah. Says, I have a complex tear of the anterior horn of my lateral meniscus. What might you treat that with? 65 years old and do have some degeneration. Injury was caused by trauma. So again, it's we would look at kind of the whole thing as a system. We would look at the entire knee and what all is involved with that. We would watch you walk and look at your gait. We would check your back to make sure that this isn't primarily coming from back as well. You know, this is the issue with, like, if you've got a blinking light in your kitchen, is the problem with the light bulb or is the problem with your breaker switch in the garage? So it's not uncommon that we see mechanics that are set up for injuries like tendinopathy that are really root cause coming from the back. And we have to treat both the tendon where it's dysfunctional, but also the nerves that are responsible for controlling the muscles to that tendon to get the best outcome. So, you know, for meniscal type tears, we typically start with a platelet type treatment, and we can inject directly into the meniscus. So we would isolate that tear and put those cells in that area. And sometimes we do have to bump up to stem cells as well, but it would depend, like I said, on all of the other things. How bad is the accompanying arthritis? Is there instability to the joint? We treat all of those at the same time. Mike Nelson says, the process you spoke about where you can view the damaged area and you can direct the needle to a specific area, is this a new procedure since 2018? No, ultrasound has been around for, gosh, I don't know, 50 plus years. And so with that, you can see damaged area around tendons and you see the needle tip go directly to it. So the point is using that imaging modality, whether it's ultrasound or fluoroscopy, to really get exactly the treatment where we want it. Ultrasound shows us a little bit more soft tissue than fluoroscopy does. And so it really lets us hone into the areas where we see the pathology. And when we treat it with a needle, we are hitting the spots that we're seeing live that are most injured. So that's interventional ultrasound. I believe this is Yvonne, says, I don't have chronic pain, but I have loss of range of motion in the hip. You limp, and would this help with that? Yeah, it very well may. And so again, the hip can be an interesting area because not everyone experiences pain in the same way. Sometimes it refers back to the buttocks. Sometimes it refers down to the knee. It's not always typical groin type pain associated with hip arthritis, but loss of range of motion is usually due to the osteoarthritis in the hip. And sometimes that capsule, the balloon that contains the joint, becomes tight as well. And so we can do a distension procedure where we blow up that capsule, just like inflating a balloon, and that can get some of your range of motion back too. So again, it'll depend on kind of the particulars of case by case, but I would expect that is something that we could help with. Mike asks, how successful have rotator cuff injuries been? Again, all of our data is transparent. It's all, our registry is all posted online. I would encourage you to go to regenexx.com, patient results, pick the body area that you're looking at, and that'll give you an average of our patients that are coming in with those conditions. As far as, specific to rotator cuff, rotator cuff injury is a huge spectrum of tendon irritation to a large front to back rupture. So depending on where we are in that spectrum is going to determine what our treatment is and how aggressive we have to get. Now, again, I've said it before, smaller injuries require less invasive procedures and larger injuries require more invasive procedures. So it's something that we treat quite commonly, shoulder and rotator cuff. And so it would just depend on the specifics of that injury. This looks like Dawn, living over 100 miles away. How many trips would be required on inside knee bone-on-bone treatment? So again, there's lots of particulars to this that we get into in our typical patient encounter. What treatments have you done so far? Are you dependent on NSAIDs? Are you able to walk independently? Do you use assistive devices? All of those things we think about all the time as far as what are our next steps and what's going to get you the best result. Typically for moderate to severe osteoarthritis, we treat that with stem cell based treatment because we get better outcomes. And typically we also treat inside the bone, as we saw on kind of the one X-ray. And so that would usually be done as a single treatment. But often when we do stem cell based treatments, we actually add a couple procedures on either side, because what we want to do is get the best possible outcome. We will often on day one inject the area with hypertonic sugar water, essentially prolotherapy or dextrose. And what that does is it primes the joint. It increases blood flow to the area, and with that blood flow comes cells. And we want the cells to kind of be there ready and waiting because we're about to inject the general contractor. That general contractor can then give orders, and if there's more cells in the area, it becomes more effective. So typically it's a day 1 prolo therapy. The following day you get off, you come back on a Wednesday, we inject marrow cells. And then that's kind of the treatment there. You get a day off, you come back on Friday, and then we'll often do some platelet injection on top of that. And it's almost like fertilizing that area. It's already primed, it's got the general contractor, and now we're adding kind of this last little boost to get everything ramped up. So for something like that, that'd be like a 3-day treatment. You'd probably be here for the whole week if you're certainly 100 miles away. And then that's the entire treatment. And we see how much it moves the needle for you. Again, we would expect those, our goal is that we're getting, a couple of years of improvement. Sometimes we need to follow that up with a platelet booster injection anywhere between 6 weeks, 6 months later. And we do find that tends to prolong the relief that patients get from those procedures as well. I think this may be our last question from Rod. It says, would you anticipate Medicare coverage in the near distant future or never? Wonderful question. Definitely not in the near future. And I'm hoping that it's not never. But I do think we're still more than a couple years away from this, because there's nothing that's marketable as far as something for insurance to kind of hang on to and say, oh yeah, we can support this group. Medical lobbying is a big part of Medicare, and the #1 Medicare lobbyist group is durable medical equipment. And so those are the people that make prosthetic joints. And so there is a huge amount of money from the lobbyists in that area, and not as much from us. So it's easy for us to kind of get pushed aside when these DME companies and surgeons can make money off of their medical equipment as well. So that's all I have in the general channel. Let me see if there's anything new in the Q&A. Yeah, it looks like I've got 2 more questions. So Jolie asks, what is the typical wait time for a first appointment? It depends. We sometimes have openings that we can squeeze patients into. We sometimes have cancellations at the last minute. We can get you on a call list. It's typically going to be within a couple of weeks. Okay. And then Brian asks, can you treat heel spurs that doctor is now recommending surgery involving the Achilles without having surgery? So the bone spurs typically aren't the primary problem. Bone spurs are actually a symptom of something else that's causing it. And in this particular case, it sounds like you've had chronic Achilles tendinopathy, which over time changes the actual cells in the tendon to calcify, and they create these bone spurs. The pain itself is coming from this, we call it metaplasia, conversion of one cell type to another. Again, it's not malignancy or cancer. This is just chronic tendinopathy. This is what it normally does. And so that's typically the source of the problem. And so it goes back to treating the Achilles itself, the substrate of the tissue, making that stronger. And then also, again, looking, do you have a low back pain? Do you have an S1 nerve compression that's causing the Achilles to not work as well as it should, that we actually have to treat the back in order to get the heel better? And so again, that's kind of the particulars for that case, but again, something we could discuss before, or more rather. And then this will probably be our last one, and then we'll kind of call it a wrap for today. But Eddie asks, do you provide taking your own x-rays, or does the patient need to provide x-rays to you? So we have x-ray here on site in our clinic. And so we can get our x-rays done here, and then we read them ourselves. But certainly if you've had prior imaging, I always like to look at it. And certainly, the preference is that we get images in addition to the reports, because not all radiologists are looking for the same things that we are. Radiology really kind of follows the suit of the surgeons, and they're looking for operative conditions, things that need to be managed by surgery is kind of like the not miss things. And we're sometimes looking for different, more subtle findings. And so again, if you have imaging, we definitely love that. We do have x-ray here. So if you come in, we can always shoot whatever we need in the office. So I think that wraps up all of the questions that I have on the chat. So thank you for everyone for joining us. Thank you for asking really, really good questions. If you have any suggestions for what kind of topic that you're interested in or areas that we can cover, definitely let us know. You can email me directly. It's Urbanek, URB as in boy, ANEK, at regenexxdsm.com. And again, that would be for if you have questions about the video or stuff. I can't really address if you're a new patient, if I haven't seen you, I cannot address any of your particular concerns via email. But if you have ideas, if you have things that you want to talk about, or if you have questions about kind of things that we mentioned during this overview, let me know. And then otherwise, keep posted. We're going to continue to ramp up this webinar series and really try to cover more specifics that hopefully will be of interest to you. So again, thanks everyone for joining. I hope you have a great rest of the day and enjoy your weekend.